Correct. Yes, ma'am. Abhijit, Vijay, Vijay. On ಮಾಡ್ಬಿಡಿ ಆನ್ ಮಾಡ್ಬಿಡಿ ಸರಿ
ಪಾಯಿಂಟ್ ನೋಡಿ ಸೆಂಟ್ರಲ್
ಇದ್ರೊಂದು ಸ್ಲೈಡ್ ಮೂವ್ ಆಗುತ್ತೆ
ಸ್ಲೈಡು ಮುಗುತ್ತೆ ಬಟ್ ನಾವು ಮೂವ್ ಆಗಲ್ಲ ಇನ್ನೇ ಇರಬೇಕಲ್ಲ ಬಾಕ್ಸ್ಗಳು ಸೊ ಇದೆಲ್ಲ ಸೆಲೆಕ್ಷನ್ ಮಾಡ್ಕೊಂಡು ಬಸ್ ಬರುತ್ತೆ
ಹೆಸರು ಬರುತ್ತೆ ನನ್ನ ಶೀಟ್ ಇದೆ ನಿಮಗೆ
ಸ್ಟಾಪ್ ಬರುತ್ತಾ ಸ್ಟಾಪ್ ಮಾಡ್ಬೇಕು
ಇನ್ನೊಂದು 5 minutes.
ಒಬ್ಬರನ್ನಿಬ್ಬರನ್ನ ಕಾಯ್ಕೊಂಡು ಹೋಗೋದು ಒಬ್ಬರನ್ನಿಬ್ಬರನ್ನ ಕಾಯ್ಕೊಂಡು ಕುತ್ಕೊಂಡು ಆಗಲ್ಲ
ಓಕೆ ಓಕೆ ಇದು ಆನ್ಲೈನ್ ಇದೆ
ಎಲ್ಲರೂ ಬರ್ತಾ ಇರ್ತಾರೆ 3 ಗಂಟೆಯಿಂದ ಬರ್ತಾ ಇರ್ತಾರೆ
खुशबू पेन ड्राइव मिल गया ये मैडम का रखो Excuse me, doctor, this is yours? Yeah. Is this one? What should these? Five? You want to check? Thank you. Good luck. अभी बुक है क्या बुक चाहिए चाहिए उनको चलता ही नहीं है नहीं तो वो यार ऑनलाइन पॉइंटर है क्या ये इसका ऑन है this is case number this one right?
हाँ, yes. So can I make sure
We are already online
because the box is not.
I'm so sorry we are already online whatever you make here is on YouTube
Then I will change it in something.
no
That's what is
it's actually too late because we'll start off in another 10 minutes we can still do it in this yes. Dr. Sushmita, I'll keep this book here. This page is still there. Huh? बिफोर ऐसे खोल के रखता हूँ बिकॉज माउस नहीं चलता। हाँ वो यही पे आपको जो चाहिए वो खोल के रखो तो ऐसे रहेगा। ठीक। ये दो टाइम भी नहीं है और मत करो मत करो प्रिपेयर किया ऐसे करो। हेलो हाँ ಓಕೆ ಓಕೆ ಅಲ್ಲ ಕೇಳ್ತಿದ್ದಾರೆ ಏನ್ ಮಾಡ್ತೀರಿ ಏನ್ ಮಾಡೋದಕ್ಕೆ ಕೇಳ್ತಿದ್ದೀರಾ? ಹೌದು ಹೇಗೆ ಸ್ವಲ್ಪ ಗೈಡ್ ಮಾಡ್ತೀರಾ? ಮೌಸಾ ಇಲ್ಲಿ ಕಾಣಿಸಲ್ಲ. ಇಲ್ಲ ಈ ಮೌಸ್ ಸರಿಯಾಗಿ ವರ್ಕ್ ಆಗ್ತಿಲ್ಲ ಅದಕ್ಕೆ. ಇದು ಗೈಡ್ ಮಾಡ್ತೀರಾ ಸ್ವಲ್ಪ? हाँ, ये बोलो ये आपको नहीं वो सबको जनरल उसको कैसे लॉगिन करके ऑनलाइन आना। This one is this one not this the pen drive you gave him that we have already loaded right case 6 case 6 right so this is case 9 KCIAPM Slide Seminar. This is the one okay thank you. See that? Very nice. Okay. This one case just have a quick look. Yeah. Postgraduates, the one presenting case 1 is the person here. Case 1. ಏನು ಮಾಡ್ಬೇಕು ಅಂತ ಹೇಳಿದ್ರೆ ಈಗ ಹಾಕ್ಲಾ ಓಕೆ ಈಗ ಗೊತ್ತಾಯ್ತು ಹಾಂ ಈಗ ಬಂದಿದೆ ದಿಸ್ ಇಸ್ ಫೈನ್ ಶೂರ್ ಶೂರ್ ಮತ್ತೆ ಏನು ಯೋಚನೆ ಅಲ್ಲ ಈಗ ನೋಡಿ ಫುಲ್ ಪವರ್ ಆಗುತ್ತೆ ಅದನ್ನ ಫುಲ್ ಸ್ಕ್ರೀನ್ ಮಾಡೋದಿಲ್ಲ ಕೆಲಸ ಮಾಡಿ ಹಾಗೆ ಇರಿ ಲೈನಲ್ಲಿ ಈಗ ನೋಡಿ ಹಾ ಈಗ ನೋಡಿ ಮತ್ತೆ ನೋಡಿ ಈಗ ಮತ್ತೆ change ಮಾಡಿ ನೋಡಿ ಓಕೆ ಬಟ್ ಅದು ಇಲ್ಲಿ ಬರ್ತಿಲ್ಲ ಆಮೇಲೆ ಇಲ್ಲ ಡೂಪ್ಲಿಕೇಟ್ ಕ್ಲಿಕ್ ಮಾಡ್ತೀನಿ ಇಲ್ಲ ಈಗ ನೋಡಿ ಡೂಪ್ಲಿಕೇಟ್ ಮಾಡಿದೆ ಈಗ ಬರ್ತಿದೆಯಾ ಈಗ ಬರ್ತಿದೆ ಥ್ಯಾಂಕ್ ಯು Final call for the postgraduate presenting case number 1. Yeah. A request for all the postgraduates, could you please seat yourself towards the screen? Please come forward. Please sit towards the screen. And the presenters could seat yourself in very well. Please, are you doing? This one? Done.
This one is the dito, na? Ano? This one dito is the I think we are trying to balance to
Then they both.
no, I always
And I know.
Good afternoon, all of you, and a very welcome from Manipal Hospital from the management team, academic section for supporting for holding this KCIAPM academic session, and also from the histopathology team. Here we cordially welcome all of you, the PGs, the associate profs, the professors, teaching staff, and also our department people, and Dr. Shiteja and Dr. Swati, who is also amongst us. Dr. Swati is a senior consultant technical methodology team over here, and ma'am has a huge experience, so if you want, you can also interact with her. And Dr. Shiteja she's the DGM Clinical Operations from the Manipal Hospital. She's here to also invite you for this session. We invite not only all of us who are present here, but also for the online viewers who will be interacting with us for the entire session, and who will be also the YouTube viewers as it is first time for us. Here for this KCIAPM sixth slide seminar, we had circulated some interesting cases. So we hope that it was useful for you all and like for your diagnosis and also approach towards difficult cases. So we are looking forward to have a very good interactive and academic section and discussion. So looking forward to participate. And be free for any questions you all have or any doubt in the entire session. We would love to interact with all of you. And for the online viewers, my colleague Dr. Anand will be carrying on for the next session how to log in online. So I just request Dr. Anand to come over. Thank you.
Good afternoon, everybody. A warm welcome again from the whole team of Manipal. And good luck for the presentations for the PGs. And for the online viewers, this is a set of instructions which they have to follow to get the best output of the video resolution. The point number one is we have to set the resolution to 720 pixels. This can be done by clicking the three dots at the top right corner of the screen and selecting the 720 pixel in quality for the best viewing resolution. Point number two is you could subscribe to the channel by clicking the logo at the lower right corner of the screen. Also, it is requested for the online viewers to participate in the discussion by posting your comments in the same section. And the audience could also rate the broadcast by clicking on the icon on the top right corner of the screen and rate the broadcast. So good luck again, and let's begin the program. Thank you.
Now I would invite Dr. Shiteja to come and just address few words to the audience.
A very warm welcome to all of you. Good afternoon, and this is a very good initiative. I would also like to share with all of you that I'm trained as a pathologist, so it's my privilege to be part of this. And I hope you continue this. So this is the sixth slide seminar or interactive seminar, and I hope you have many more to come. All the best.
So let's begin with the program. The postgraduate presenting the case number 1 has not turned up yet. Apologies for that. So we'll now go forward with the case number 2, which will be presented by Dr. Jyoti Reddy from Rajarajeshwari Medical College, Bangalore. Yeah.
Good afternoon, everyone. I'm Jyoti from Rajarajeshwari Medical College and Hospital. The case allotted to us says it's a 2-month-old female child with a swelling in the
maxillary area. And this was the photomicrograph provided, which shows there is a bony trabeculae at one end and there is a partial capsule at the other, which turned out to be stratified squamous epithelium on higher magnification. So it's a well circumscribed tumor with bimodal population of tumor cells. One is the small round blue cells, which we could see in the clear spaces, and the other one is the pigment containing cells. On further higher magnification, these small round blue cells are arranged in nests, sheaths, and here in pod-like fashion. The pigment-containing cells are arranged in pseudoalveolar and pseudoglandular patterns. This is the high magnification of the bimodal tumor cells. One is the small round blue cells and the other one is the epithelioid-like pigment-containing cells. Further, in higher magnification, these basophilic cells are blast-like with high density ratio, and there is prominent salt and pepper-like chromatin at some places, which is constant with that of the arrow. These epithelioid-like cells are the second population, which are polygonal or round in shape, and they have abundant eosinophilic cytoplasm, prominent nucleoli, which are pointed here, and some of these cells show melanin pigment, that is the melanin granules in the cytoplasm. This is the fibrous collagenous stroma, which has scattered melanin pigment as well as mononuclear inflammatory cell infiltrate. Here we can see the tumor cells infiltrating in between the bony trabeculae, making it as locally infiltrated tumor. So we could think of other diagnoses of small round cell tumors like neuroblastoma and Evans tumor, but we could differentiate them because they do not contain any pigment. And alveolar rhabdomyosarcoma, though there is that pseudoalveolar pattern, but then the spindle-shaped cells and melanin pigment would be absent here. And lymphoma, again, melanin pigment would be absent. Malignant melanoma, usually the presentation would be nasally and there would be no small round blue cells. And clear cell sarcoma of the soft tissue, it contains this, there will not be any melanin pigment and it would contain these giant cells. So our approach to diagnosis was based on both clinical history as well as the microscopic features. Infant with the premaxillary swelling and this bimodal tumor population with melanin pigment, there was no necrosis, mitosis or hemorrhage in the sections and there was locally infiltrating the bone. So we could give the diagnosis of melanotic neuroectodermal tumor of infancy, which is MNTI, otherwise called as retinal enlarged tumor. So further, we could confirm the diagnosis with the help of INC markers for both melanogenic and neurogenic cells. Vimentin, NSE, and synaptophysin would be positive for both the cells. Cytokeratin is positive for melanogenic, and cytokeratin would be negative for neurogenic cells. Both are S100 negative. Thank you.
Very good presentation, Dr. Jyoti. Now, Dr. Kushnu, a consultant working in our lab, would be presenting the case number 2, the significant findings and the final conclusion for that.
Thank you, sir. And good afternoon, everyone. Now, moving on to case, the history provided was female child presenting with spectacular maxillary disease. Further, this child presented with the chief complaints of rapidly growing swelling in the oral cavity since last 3 weeks. And on examination, spherical swelling was found in the premaxilla measuring 3.5 by 3 centimeter, which had a smooth surface covered by oral mucosa and it On cross-examination, the tumor was globular, surface and had a 3 by 2.5 centimeter. Extracellular form graphite and it showed areas of gray brown discoloration. This is the scanner view microphotograph. The lower border of the tumor, as you can see, is the circumscribed, while the upper border has irregular infiltrative margin. And we can see some bony trabeculae at the upper border of the tumor. On higher magnification, we can see the tumor is infiltrating and destroying the underlying bone, and the tumor has alternately pale as well as pinkish area. This is the high microscope to show the morphology better. Here we can see bimodal cell population arranged in alveolar pattern. These are the alveolar spaces. The center of these alveolar spaces contain small blue round small blue round neuroblast-like cells, while the periphery contains the large eosinophilic epithelioid cells, as rightly explained by Dr. Jyoti. So this on higher magnification we can see this larger epithelioid cell, many of these cells show the cytoplasmic brownish to blackish color pigment. So summarizing the finding, this is a tumor child presenting with rapidly growing maxillary swelling, and on histology it has a characteristic bimodal cell population arranged in the alveolar pattern, so that reaches the diagnosis of melotic neuroectodermal tumor of infancy. Coming to the theory part, it is a very rare rapidly growing tumor. It is totally benign, though it is locally destructive. It was first described by Baker in 1918, and it arises from the neural cleft cell. It was suggested by Morello and Hawley in 1966, based on the finding that many of these tumor cells secrete valinal mandelic acid, which is the neuroectodermal tumor as well. This tumor is commonly seen in children in the first year of their life, more commonly in the first 6 months, but it is never congenital, and it is slightly more common in the male population. 90% of these tumors they involve the head and neck region, and among the head and neck region, the commonest site being the maxilla. Other common sites in the head and neck region are skull and mandible. Besides head and neck region, it involves the other sites as well, like brain, appendectomy, ovary, uterus, etc. And the child typically present with a history of rapidly growing mass over a duration of few weeks. So differences basically are considered based on the clinical history of rapidly growing as a neuroblastoma, rhabdoma, and sarcoma, and congenital. And the differential tumor can also be considered as a clinical possibility, because these also show a bluish blackish discoloration and commonly present in the head and neck region in the child. So while diagnostic workup, various radiological investigations are done in order to localize the tumor, but incisional biopsy helps in the confirmation of the diagnosis. Other investigations can be urinary DNA level, though it has a low diagnostic rate. One histology is the gold standard for diagnosis because it has this characteristic alveolar pattern and bifurcated cell population. As it has been, I won't go to add is both of these cell populations, with small neuroblast-like cells as well as the larger peripheral epithelioid cells, both are positive for NSC, and both are positive for NSC, while the larger epithelioid cell in addition they are positive for HMB45 and PANS. So treatment is by peripheral excision with 2 to 5 mm of margin. Prognosis, it has got a local recurrence rate of about 10 to 15%, and age is considered to be a strong prognostic indicator because infants who present within the first 2 months are found to have highest risk of recurrence, while those who present after 4.5 months of the age have got minimal risk of recurrence, and in between there is an intermediate risk. These are the references. Thank you. Any questions?
Thank you, Dr. Kushbu. A good presentation. This was quite a straightforward case, and I hope you would have enjoyed seeing the slides. Now, apologies for the delay in the presentation of case number 1. We'll just take a minute and add the case number 1 and try to present it. Dr. Sonia from SDUMC Kolar will be now presenting the case number 1. Over to Dr. Sonia.
Good afternoon, one and all. I'm Dr. Sonia, second year postgraduate resident from the Department of Pathology, STUMC. So I'll be dealing with case 1. A 62-year-old female presented with a brain tumor specimen. This was the section which was seen on the scanner view. Here on little magnification, we can see these meningoendothelial cells along the lining of the dura. These are not very prominent, but if we trace the dural lining, we can clearly make out the meningoendothelial cells. In this section, we are able to see numerous cystic spaces and blood vessels. These blood vessels are dilated and they are thickened. Here on the little magnification, we can see these interstitial cells with indistinct cell membranes and eosinophilic cytoplasm. And here we can make out the lobulated architecture with meningoendothelial walls. So, on the basis of the above histopathological findings, the differential diagnosis which we could make out was one is angiomatous meningioma because of the meningoendothelial lobules and the meningoendothelial cells which were seen along the lining of the dura. That is angiomatous meningioma WHO grade 1. And the second differential diagnosis could be hemangiopericytoma. The immunohistochemistry panel which we can run for such cases could be CD34, BCL2, epithelial membrane antigen, MUC1, Ki67 for the proliferation of the cells, P63 and S100. Thank you very much.
Thank you, Dr. Sonia. Excellent presentation again. Any questions so far? So now Dr. Khushbu again will present case number 1. Yeah. Okay.
Thank you, sir. Coming to case number 1, the history given was brain tumor in a 62-year female. This patient presented with chief complaint of headache and vomiting and partial seizure with secondary generalization. On physical examination, patient was alert and conscious with GC scale of 15 by 15 and vitals were stable. On CNS examination, no deficit was found and her higher liver function were within normal. All the other systemic examinations were within normal limit. MRI picture of the brain. This is from the coronal view, and here we can see dural base to cerebral convexity mass showing a prominent dural tail, and it is compressing on the surrounding brain parenchyma. On surgical findings, surgeon found the mass to be extra-axial. It was vascular and easily separable from the adjacent cortex. The mass was excised and blocked and sent to Department of Histopathology. On cross examination, it was a globular mass measuring 3 by 3 centimeter with a smooth surface, and the cut surface was formed, gravid, and showing a few cystic areas. This is a scanner view microphotograph of the mass showing here the lobulated Here showing the smooth outer surface. This is the section view from the periphery of the lesion, showing the dural attachment of the tumor. And in addition, it has got numerous dilated cystic spaces and hyalinized blood vessels. Further closer view to better appreciate the dural attachment of the tumor. This is the representative microphotograph of the tumor, here showing multiple punched out cystic spaces and these hyalinized blood vessels. For the closer view from the cystic areas, here we can see the cystic spaces, and within these cystic spaces are spanning this elongated cytoplasmic process of stellate cells. Another photograph to better highlight there is the elongated cytoplasmic process of the stellate cells which are spanning in these cystic spaces. In addition, the tumors have numerous hyalinized blood vessels as well. This is the area from the solid part of the tumor showing the meningothelial arrangement of the cells and which wall formation. Higher magnification is the distribution of this meningothelial cells. Summarizing the finding, it was a dural-based mass in a sincere female which showed dural death on a microscopy. There were numerous microcystic spaces, predominantly, though there were high blood vessels also, but the predominant component here was the presence of the microcystic spaces. So based on that, the final diagnosis of microcystic meningioma WHO grade 1 was made. Now coming to the theory part, meningioma are the dural-based benign, mostly benign pseudopoid neoplasm arising from the meningothelial cells of the arachnoid. Common in female and with the median age of 65 years. Though higher grade tumor are slightly more common in males, the only proven established environmental risk factor found to have role in the pathogenesis of meningioma are the allergic radiation. And it is found that the higher among those who are exposed in childhood than as adults. About common mutations for the meningioma are the final orbital location. The intraventricular location have also been reported. Among the intracranial mutations, the common sites are the cerebral convexity, olfactory groove, sphenoid ridges, para, and intracellular region. Now, the meningiomas have been divided into three grades based on their biological behavior. The majority of them fall into the grade 1 category. Now, to diagnose grade 2 atypical or the atypical meningioma, various criteria has been made. Either any meningioma which is showing three of the following five features, or if there is mitosis of more than 4% hemoglobin up to 20, or if brain invasion is present on histology, then that will qualify as a grade 2 or atypical meningioma. The morphological variants included under the grade 2 meningioma are choroid meningioma and the PSL meningioma. The anaplastic or the grade 3 meningioma, it is a malignant meningioma which shows the markedly elevated mitotic count of more than 20% hemoglobin, or it should have overtly malignant cytology, carcinoma, melanoma, or hybrid sarcoma. The morphological variants included in the grade 3 meningioma, the papillary and the rhabdoid meningioma. The grade 2 and the grade 3 meningioma are believed to have greater likelihood of recurrence and aggressive behavior. Now, WHO 2016 has updated brain invasion as a criteria to classify the meningioma as a grade 2 meningioma, which was not there previously. And this categorization has been based on the finding that whether it is the low grade or the high grade meningioma, if the brain invasion is present, the risk of recurrence is similar in the even in the low grade meningioma also. So based on that finding, brain invasion as a criteria to classify meningioma as a grade 2 meningioma. Now, how do you define the brain invasion? It is defined as the presence of irregular tongue-like protrusion of the infiltrating cells in the underlying brain parenchyma, but there should be no intervening layer of the meninges, leptomeninges. Higher magnification to show these infiltrating tongues of the meningothelial cells in the underlying brain parenchyma, and there is no intervening leptomeninges detected. So that qualifies as a brain invasion. On highest most of the on specific. In addition, they are positive for EMA and PR, which is more in the grade 1 tumors, and the proportion of positivity goes on decreasing with the grade of the tumor. The other marker found to be positive is the somatostatin receptor 2A, which is different and strongly positive, but it is not specific as it is encountered in the endocrine neoplasm as well. Now coming to microcystic meningioma, few words on it, which is a WHO grade 1 tumor. It constitutes only 4.6% of the intracranial meningioma. This particular microcyst may be visible either grossly or radiologically. On MRI, significant amount of peripheral cerebral edema is present, because of which clinically it may mimic the high-grade tumor. And microscopically, it is characterized by the presence of the thin elongated sterile cells present within the microcystic microcyst, which gives the appearance of fountain. Degenerative nuclear reticular is quite common in them, and often intermixed with it, angiomatous component is common. That's all for you. We saw the differential diagnosis of angiomatous meningioma, angioblastoma, and very, very few case reports are there which have microcystic meningioma in which mimic PXS. So it has also been put in the differential diagnosis. Thank you. Any questions? Okay, because in hemangiopericytoma, it has a characteristic branching HPC-like vessels which we say. But here the vessels which we saw were typically highly nice and circular. It didn't have that HP, that branching vascular pattern. And in addition, HPC we get small cells which has more of bluish nature. That means we do not get such type of cells having abundant cytoplasm, maculated cytoplasm in HPC. We have typically round blue cell-like morphology. And depending upon the grade, if it is like grade 1, we can have the differential of fibromatous meningioma in that. But grade 2 and grade 3 HPC, they typically have small round cell-like morphology with HPC-like branching vessels. So that is why that was not my differential. Anything else?
Slide seminar is basically for the PGs, so I would request anybody with doubts or any slightest aspect of the open up it, find out the questions. Thank you, Dr. Krishnu. We'll now move ahead to case number 3, which will be presented by Dr. Nimisha Gupta from Vaidehi Medical College.
Good afternoon, everyone. I am Dr. Nimisha Gupta from Vaidehi Institute of Medical Sciences and Research Center. I'll be discussing about case number 3. History given to us was 14-year-old female presented with extra-osseous and intra-osseous lesion of right proximal tibia. So the whole slide shows two tissue beds, which further on the scanner view showed us with partially circumscribed lesion consisting of sheets of inflammatory cells along with numerous foamy macrophages. Further on the high part, we can see sheets of mixed inflammatory infiltrate consisting of lymphocytes, plasma cells, and histiocytes. This is a high part view showing histiocytes having abundant pale eosinophilic to vacuolated cytoplasm, having round to oval nuclei, fine chromatin and inconspicuous nucleoli. Few of the histiocytes on the low part show us emperipolysis. This is the high part view of emperipolysis showing phagocytosis of lymphocytes, lymphocytes, neutrophils, plasma cells by histiocytes. Occasional neutrophils and eosinophils lining fibrous stroma was also seen. As I discussed earlier, numerous foamy macrophages were noted. One of the photos showed fibroblasts arranged in fascicular pattern interspersed with mature adipocytes, collagen fibrils, and congested blood vessels. So this is a summary of my microscopic findings. Sheets of inflammatory cells, that is lymphocytes, plasma cells, histiocytes, and location neurons and histiocytes lining fibrous stroma. Few of the histiocytes show empiric polycysts and numerous moving macrophages, and fibroblasts are noted arranged in fascicular pattern. No evidence of atypical mitosis or necrosis is seen. After considering all the microscopic findings, my differentials are: my first differential is Rossi-Hoffman disease, second is Edwin-Chester disease, and the third is lentopramomerous osteomyelitis. So the points favoring Rossi-Hoffman disease are the age, because it's more common in children and young adults, and the location. It is intraosseous as well as extraosseous location. The site, it's more common in long course, and peripolysis, which is a characteristic feature of Rossi-Hoffman disease. The second differential, the Erdheim-Chester disease, the points favoring are the site, the location, and the numerous moving macrophages and mixed inflammatory infiltrate. The points which are against is Erdheim-Chester disease is more common in 50 to 70 years old, and it's more common in the males as compared to females. And emperipolysis, which is a characteristic feature of Rossi-Hoffman disease and not Erdheim-Chester disease. My third differential is lentopramomerous osteomyelitis. The points favoring are the foamy macrophages and mixed inflammatory cell infiltrate, and against is it's mostly intraosseous, where the slide given to us showed us intraosseous as well as extraosseous lesion. So after considering the differentials, my final differential is, my final diagnosis is Rossi-Hoffman disease. Thank you.
Thank you, Dr. Manisha, for your presentation. Now, Dr. Anand will be discussing this case. Thank you.
Yes, Dr. Divisha, spot on. The diagnosis is correct, as given by you as well as given by the other postgraduates in their email responses. So, big round of applause for Dr. Nimisha. She's gotten it right. So to begin with, this was a pretty simple, straightforward case. If you just go by the histological appearance, but unusual presentation here was that the history given was lesion within the bone within a young child. So let's begin with the clinical history to clarify or put light on some other aspects that we haven't seen so far. This was a 14-year-old female. It was a referred case from an outside hospital. The patient presented with pain and swelling in the right leg since 1 year, with an increase in size after an injury which happened a month back. Earlier, the patient was diagnosed as a case of uricemia, and she was also given uricos serum uric acid was just borderline level, that is 6.4, and because the disease did not subside, a core needle biopsy was performed at the outside hospital, and a descriptive comment was given as section shows sheets of plasma cells along with inflammatory cells and fibrous tissue. However, an advice on ruling out the presence of solitary plasmacytoma was also suggested using immunohistochemistry for CD138, kappa, and lambda. But the case was referred to us because even after this diagnosis, the clinicians weren't really satisfied. And so we begin with our lab investigations here. The blood counts show anemia, 8.7 of hemoglobin, with predominantly a microcytic hyperchromic picture. The other blood counts are normal. The WBC and differential counts are normal. Platelet counts are normal. Nothing significant otherwise. Because a plasmacytoma was suggested by the previous pathologist, we performed tests for serum and urine protein electrophoresis. Now, both of these did not reveal any M band or any significant changes. The serum kappa and lambda ratios were quite within normal limits. So at least a plasma cell dyscrasia was ruled out in this case at this level. Next, because of the appearance of a mixed inflammatory infiltrate, various cultures were also performed, including the aerobic culture and gene expert for MTB, which was again negative. So after the labs, we weren't left with any important diagnostic clue. Still, the radiology pictures were as follows. The X-ray showed a translucent lesion in the region of the proximal metaphysis of the tibia, and there was no periosteal reaction or a cortical breach. Hence, a benign etiology was suggested here. Again, no accurate diagnosis. Again, a PET scan was performed, which showed a tibial lesion, which was FTG active. A suggestion of a plasmacytoma was given, and also noted were multiple metabolically active lytic lesions, which were seen in the axial and appendicular bones, and they suggested again a neoplastic pathology. Further ahead, it was taken into the OT, and the lesions were excised from the right proximal tibia. Both an extra-osseous lesion and an intra-osseous lesion were excised. The extra-osseous lesion, which was presented to us in the lab, was a single mass which measured around 3 centimeters in size. The intra-osseous lesion came in multiple bits. This is the lower view which we can see. I'll try to use the mouse here because the online viewers can also see the pointer then. We see a large pale area here in the center on the lobar appearance, and the surrounding area shows a very busy appearance with numerous lymphocytes, which I can see at this magnification. Coming to a higher magnification, we see the close-up of the pale areas are actually sheets of foamy histiocytes, and the areas surrounding show sheets of inflammatory cells. What these regions are composed of are quite obvious here on the highest magnification. On the right half of the image, you can see sheets of histiocytes which are in various sizes. There are some smaller ones which are in the center here, whereas the larger ones which are out here towards the periphery, you can see that they have characteristic description of a histiocyte. There is a central nucleus. There is a small nucleus, a nucleus here with a prominent nucleolus and vesicular nucleochromatin with abundant foamy cytoplasm. This is a classic description of a histiocyte. And within the cytoplasm, you can see various cells all over in this picture. Like in this cell I began with, you can see a plasma cell. And in this histiocyte, we can see multiple neutrophils. And on the top here, in this histiocyte, we can see numerous lymphocytes and RBCs as well. The other half of the image shows sheets of plasma cells with occasional lymphocytes in between, which are again highlighted here. In the top left image, you can see a binucleate histiocyte. A binucleate plasma cell also is seen here. And in the right bottom image, we can see multiple such histiocytes in sheets, again showing prominent process which we call as emperipolysis. That is the presence of intact lymphocytes within the cytoplasm of the histiocytes. We see such cells in abundance. We know the diagnosis. So it was quite obvious. Now, the final diagnosis in this case was Rosai-Dorfman disease of the bone. These are the gentlemen who discovered this or named this, identified this disease, Johann Rosai and Ronald Dorfman. So, Rosai-Dorfman disease is clinically also called as, or was earlier called as sinus histiocytosis with massive lymphadenopathy. We saw the sinus histiocytosis on the histology. Now, these are clinical pictures which show the significant and or massive lymphadenopathy, which is most commonly seen in the cervical and the axillary regions. Though the commonest presentation is of a nodal disease, we also see 40% of the cases which present with extranodal disease. And the most common sites of extranodal presentation are in the skin, upper respiratory tract, soft tissue, the gastrointestinal tract, bones, breast, and the CNS. So it is a very obvious known thing that bones can also show us Rosai-Dorfman disease. So there is no surprise in this case. Just a recap of the histology once more. A mixed inflammatory infiltrate in the background. Large pale cells are seen in abundance, which are histiocytes proven by CD68 positivity, S100 positivity, and a negative CD1A. This is very important to differentiate from one of the closest TDs. Then emperipolysis is the hallmark feature here. Treatment options include surgery, steroids, radio, or chemotherapy in very aggressive or extensive cases. Coming to the discussion of DDs, a mixed inflammatory infiltrate would suggest an infection or an abscess, but our culture reports, including gene expert, were negative, and the emperipolysis was very prominent here. So infection or abscess is less likely. The presentation of the disease in the bones made us think of plasmacytoma in this case. However, the absence of any M band rules out a plasma cell dyscrasia overall. With specificity to plasmacytoma, usually in plasmacytoma we see sheets of plasma cells, either the mature forms or the binucleate ones, and there is less abundance of the histiocytes with emperipolysis, which is completely absent in a plasmacytoma. The very important DD. In fact, we label these cases as non-LCH histiocytic disorders favoring Rosai-Dorfman disease. So LCH becomes a very important DD. However, the differentiating factors are right from the histology. The classic appearance of the LCH cell would be a grooved nucleus of the histiocyte, and then there's abundance of eosinophils in the background, and also a positivity for CD1A, which I showed in the earlier slide, would be negative in Rosai-Dorfman disease. Coming to the fourth DD, that is anaplastic large cell lymphoma. When we see this disease in lymph nodes, it is more, the histiocytes are seen more within the sinuses, as well as the ANCN cells, which also have a sinusoidal spread within the lymph nodes. So it is very important to distinguish these two if there is somewhat a close resemblance between them. So how we differentiate is we use immunohistochemical markers. We have a classic triad of ALK, EMA, and CD30 coming positive in ANCL, which is negative in the Rosai-Dorfman histiocytes. Also missing is the important emperipolysis. Metastatic neoplasms within the lymph node sinuses can mimic these histiocytes. However, a positivity for CK or EMA rules that out. Chronic granulomatous inflammation has a close picture with Rosai-Dorfman because of the increase in the number of histiocytes, but the presence of granulomas as well as the presence of emperipolysis in Rosai-Dorfman would sort this out. This is a reference, Atlas of Lymph Node Pathology. It's a very useful book if you can get your hands on it by Roberto Miranda. Any questions to the audience? It's quite a straightforward case. I do not want to lose much time on this because the next case is quite a tough one, what UPG would call it as. So, any questions quickly? So, if there are no more questions, we'll move to the next slide, next case, which will be presented, that is case number 4, which will be presented by Dr. Ashwini J from Basveshwara Medical College in Chitradurga. Yes.
Good afternoon, one and all. Myself, Dr. Ashwini Jamgi from Basveshwara Medical College and Hospital, Chitradurga. Case given to us was case number 4 with the history as 18-year-old male, incision biopsy of ulcerative proliferative growth from the right elbow. Of the multiple sections studied, one of the tissue bed is lined by epidermis and infiltrating tumor is noted in the epidermis. Tumor is cellular with haphazard arrangement of tumor cells with intervening blood vessels. Individual tumor cells are pleomorphic with round to spindle hyperchromatic nuclei and scant clear to eosinophilic cytoplasm. Stroma shows extensive myxoid changes, which is evident in more than 50% of the tumor tissue, and also areas of focal hyaline change and necrosis are seen. Tumor germ cells and inflammatory cells, mainly neutrophils, are seen in the stroma, and most of the blood vessel walls show neutrophilic infiltration, and few blood vessels are thrombosed. One mitotic figure per 10 high power field. So to summarize the findings, it is an infiltrating tumor located in the dermis and subcutaneous tissue of the elbow in an 18-year-old male. It is a cellular tumor with marked heterogeneity. Tumor cells are spindle and pleomorphic and haphazardly arranged. Stroma shows extensive myxoid change. Vasculature, blood vessel wall is infiltrated by neutrophils in most of the areas, and few blood vessels are thrombosed. Neutrophilic infiltration is seen in the stroma, and 1 per 10 high power field mitotic figures are seen. Based on these findings, my differential diagnoses are myxoid malignant fibrous histiocytoma or high-grade myxofibrosarcoma, myxoinflammatory fibroblastic sarcoma, pleomorphic hyalinizing angiotensin tumor of soft parts. Features favoring the chronological order of my differential diagnosis are
High-grade myxofibrosarcoma is located in the dermis and subcutaneous tissue and has haphazard pattern of tumor arrangement, has pleomorphic tumor cells, 1 to 8 per 10 high power field mitotic figures are seen. Myxoid change is evident in more than 50% of the stroma, and tumor germ cells are also seen in the stroma. Features favoring myxoinflammatory fibroblastic sarcoma are location of the tumor, pleomorphic tumor cells, 0 to 1 per 10 high power field mitotic figures, myxoid change, and tumor giant cells in the stroma. And pleomorphic hyalinoizing angiotic tumor will have subcutaneous location but can extend to dermis. Pleomorphic tumor cells and less than 1 per 50 high power field mitotic figures are seen. However, diagnosis can be confirmed by immunohistochemistry. High-grade myxofibrosarcoma is positive for vimentin, smooth muscle actin, and negative for desmin and histiocytic markers such as LU3, UM3, and CD68. Myxoinflammatory fibroblastic sarcoma is positive for vimentin and shows variable positivity for CD68, CD34, and smooth muscle actin. It is negative for S100, HLB45, desmin, EMN, LCA, CD15, and CD30. Pleomorphic hyalinoizing angiotic tumor is positive for vimentin, CD34, and epithelial membrane antigen, negative for S100. Thank you.
Thank you, Dr. Ashwini. A very good presentation, quite discussed quite in detail with the ISC findings. So to begin with, case number 4 was what you would all call as extremely tough case, which we would have had no idea about what the diagnosis could be. Let's make this the real intention of doing a KCIAPM slide seminar is being interactive. So let's come up with some answers. I'll be shooting some questions into the audience. So please, I hope all of you are postgraduates here, at least the majority of the crowd. So you can just scream out your answer whenever I raise a question. Okay. So no identification, no punishment, nothing like that. So just come up with the answers, please. So to begin with, we'll start with a brief clinical history. It's an 18-year-old male from Bangladesh who had a right forearm swelling with pus discharge since about 6 months. The CBC was normal, and back at Dhaka, they did an FNC which was reported as consistent with a high-grade sarcoma. And then a core biopsy also was done, which was reported as an invasive squamous cell carcinoma. Now, the clinicians who would have seen these reports would have been thoroughly confused, and so excision biopsy was further performed, which was given as a third, completely different diagnosis, a completely different lineage to say. It was reported as an NHL of the intermediate grade. Intermediate grade doesn't exist now. So, a clinician would have thought we pathologists are from another planet totally, and these diagnoses also would make no sense, and they would be at their wits' end to manage such a case. And so, the case was further referred here, or I think the patient preferred us. So, coming to the radiology, MRI of the right elbow region was performed. Well-defined lesion with post-contrast and avid enhancement measuring 5 centimeter by 4 centimeter approximately was noted in the subcutaneous plane. Again, our suggested diagnosis was just a query neoplasm. So even they were helpless. And to rule out other diagnostic considerations, CT thorax was done, which was well within normal limits. So again, even from the radiology, we don't have much of a clue here. So going ahead with the lab investigations, the serum LFTs were performed, which showed mild variations in the total protein, in the globulin, and the AG ratio. Again, very minimal changes. When we are thinking of lymphoma on the cards, we always do serum LDH and the serum uric acid. LDH points in general to lymphomas, and also, yeah, it is expressed in other tumors like the germ cell. And uric acid is performed when we are thinking of lymphoblastic lymphoma or leukemia. Both were normal. And yeah, when we're considering lymphoma leukemias, we do the CBCs also. Again, all we saw in this case was a mild change within the hemoglobin and the RBC indices. The other parameters like WBC counts and differential counts and the platelets were all normal. So jumping into the histopathology, because none of these other lab investigations really gave a clue to us, an excision biopsy again was performed, and this is a low-power image of the tumor. To the right of the image, we see squamous epithelial islands and focal budding into cords here, and the rest of the image is composed of a tumor here to the left half. And we see within the squamous epithelium there is not much cellularity or an increased proliferation happening. If you see the other part of the tumor, you can see many cells in a single field. So this is a cellular tumor here. However, the squamous epithelium overlying it did not show such cellularity. What they show instead was few neutrophils scattered within the epithelium. Now, this could have caused a little bit of inflammatory ATPR, as you see towards this protruding edge here. And that ATPR, if a biopsy which was performed at Dhaka had passed through this plane, I don't know, had passed through this plane, it has seen few atypical squamous cells here along with the underlying tumor that would have prompted them to diagnose it as a squamous cell carcinoma. But again, that was not the case here. So, other than that, what we find here are a cellular tumor which is seen in groups and also scattered within the surrounding edematous or myxoid stroma all around. We'll go to a higher magnification. In this magnification, we can see a central vessel with the endothelial cells being slightly activated. And around these the blood vessel, we can see sheets of tumor cells, which are more or less arranged around the blood vessels. So this is characteristically called an angiocentric appearance of the arrangement of the tumor cells. Now, as we go deeper, the tumor cells are in sheets almost, and so we have a cellular tumor here, and also how is the pleomorphism seen? It is highly pleomorphic. Like if we see this cell here, this is a tumor cell which contains hypochromatic nucleus, and it is of the same size as the endothelial cells, which is lying adjacent to it. Around the vessel, you see medium-sized cells, and quite a little further, you see large cells, which have quite a big nucleus, very pleomorphic nucleus, and increase in the number of nucleoli seen. Also important in this slide is numerous mitotic figures. Like this will be one mitotic figure which I will be able to point out. I don't know if you can appreciate on this slide, but there are numerous mitotic figures also in this case. So the same features are again appreciated on this slide. So what do we ultimately label it on, even on histopathology? We have an undifferentiated tumor. We do not know whether this is a sarcoma or a lymphoma or a carcinoma still. We are back to square one. But it is a malignant tumor when you consider three important aspects. That is high cellularity, increased pleomorphism, and a very high mitotic rate. So now it's time to find questions. So what do you do next, PGs? If you get a case which looks like this in your exam, what do you do next? What is the important choice of investigation or test which you would want to do next? IHC, very good. So all of you uniformly consider IHC is the best solution? I do agree with that, but partially, because when you consider the list of IHC markers clinically available, this was taken from an article which appeared in Archives of Pathology and Lab Medicine in the December 2014 issue. Now, back then we had so many markers and so many tumors, you can't really just start doing an IHC without a proper approach. So, whenever we are stuck with a situation in practice or in life, we make a logical analysis of the situation, and that's what these authors in the article have done. So, they've begun with a proper diagnostic algorithm. But to begin with, they don't start with IHC. Instead, you go back to the other data which is available from the clinical side. So to begin with, we review the histomorphology of the case without any clinical information, and we make a broad list of DDs, include as many number of differential diagnoses you want, 5 to 10, and then consider the clinical information provided: the age, sex, location of tumor, and if there was a prior malignant report. Include all those and re-evaluate the histomorphology. Come back to top 3 or 4 main differential diagnoses. If you have a clear-cut lineage differentiation, you can go to the left side of the diagram where you can further use specific markers to confirm that. If you do not, then come back to the right half of the image where you have the undifferentiated tumor with no lineage differentiation again. So at this point, the authors suggest us to use 4 important IHC markers which can be used as a broad lineage determination markers, that is cytokeratin, S100, vimentin, and CD45. Using this, you can drop our tumor, specific tumor, the case in hand, into one of these 4 boxes on various combinations. The first box here, to begin with, is shows those tumors which are only CK positive. Second box is dual positivity of CK and vimentin. Third would include cases with vimentin positivity. Fourth would include cases with vimentin and S100. Fifth would be the LCA positive cases. Now again we come to a busy slide. Apologies for that, but I wouldn't be going into the details here. This is the first box divided further into multiple categories. The box is showing the cases which are cytokeratin positive and negative for all other markers. So here we further use 2 specific markers, cytokeratin 7 and cytokeratin 20, to differentiate or categorize tumors according to their organ systems. Now, using a various combinations of this CK7 and 20, if CK7 would be positive alone, it would be these different tumors. If it was CK20 positive, it would be the left half of the figure. And if it was a dual positivity of CK7 and 20, it would be these tumors. And if it was a dual negative for 7 and 20, there are a specific set of tumors. This could further be read up in the article. I'll give you the reference at the end. But those were all the tumors which would be CK positive. But if it is a combination of CK and vimentin, we have a unique set of carcinomas and sarcomas, which would depict this kind of a presentation. Coming to the third box, where you have a positivity only for vimentin and with or without S100, all of the sarcomas would be included here, and the very few and unusual carcinomas or lymphomas may also fall into this category. Melanomas also significantly are vimentin and S100 positive. And coming to the last category, CD45 positive tumors, as we all know, are lymphomas. They are further approached as division of non-Hodgkin's and Hodgkin's lymphoma, and few rare other tumors like myeloid sarcomas, histiocytic or dendritic tumors. NHLs are further divided into B cell, T cell NHLs or ALCL. So just to do a quick recap, we have to put our tumor into one of these boxes, which are differentiated by the main 4 markers. Now, what happened in our case was, on the top left, you will see the cytokeratin positivity within the squamous epithelium. How the tumor cells underlying are clearly negative, and S100 was completely blank within the epithelium as well as within the tumor cells. We can see the vimentin and the CD45 have highlighted the tumor cells significantly, and the epithelium again over the left half of the image is negative. So, what is the scale? What is the diagnosis now? Yes, louder. Lymphoma. Yeah. So now we have a lymphoma on the cards, but then WHO has nearly 100 or over 100 types of lymphomas described in it. Just to emphasize that further, CD45, as you see, this perivascular or angiocentric arrangement of tumor cells with diffuse positivity for CD45. So it checks into that last box where CD45 was positive. And again, coming to the specific flowchart of LCA positive tumors, we have to further differentiate these in using B cell markers, T cell markers, or Hodgkin's lymphoma markers. So we have done that further, which we will go through all that. You have to note that particularly taking pictures with the angiocentric arrangement of the tumor cells. So CD2 is significantly prominent within the tumor cells, whereas only few cells are positive for CD5. And the rest of the T cells markers, including CD3, 7, 4, 8, and even ALK, were negative in this case. So it is somewhat positive for T cell markers. And the B cell markers were all negative, except MUM1, which showed focal positivity as seen in this lower image. Other markers were done, which is CD30, which was diffusely positive on the top. KS67 also was diffusely positive. So this is a highly aggressive tumor, mitotically very active, with an increased CD30 and CD45 positivity. Now, other markers, here is a small quiz for you guys. Other markers which were negative in our case, I'll read the marker out. You can quickly scream out the tumor it is likely to be positive in. P40. Come on, PGs. Squamous cell carcinoma. EBV and CD15. Hodgkin's lymphoma. Very good. Desmin. Muscle marker. SMA. Smooth muscle marker. Very good. Myod1. Rhabdomyosarcomas. CD99. Yeah, a big list of tumors, most importantly in wings. CD56, neuroendocrine and other tumors, like even in T cell lymphomas. CD34, vascular tumors. Anything in hematolymphoid systems, stem cells also, and also including the myeloid sarcomas, which could be positive here. So yeah, now you've done your homework. Also, a positive was the EMA, which was found here, okay, in few cells. So what do we have here? We have a cutaneous lymphoma, which is positive for T cell markers, CD30 diffusely, and MUM1. And so it puts us, we have a diagnosis of cutaneous lymphoma, which is positive for T markers, MUM1, and is ALK negative significantly. So this is the WHO list of again cutaneous lymphomas and leukemias, broadly again divided into B cell primary and secondary lymphomas, or T cell primary and secondary ones. Now, if we want to put our tumor into one of these, it becomes very easy at this point because we have a category which is reflecting our case here. So we have a primary cutaneous CD30 positive lymphoma category. Which has three entities here. Lymphomatoid papulosis on the top is a benign condition. The second, cutaneous ALCL, is a malignant condition, and there are borderline cases in between. This happens to be the second most common group of cutaneous T cell lymphomas. Any guesses on which is the first most common T cell lymphoma in the skin? Very easy. Only one you would have heard of. Very good. Excellent. So you're on the way. So cutaneous ALCL, by definition, shows more than 75% of the cells being CD30 positive, which was obvious in our case, and it is the second most common cutaneous T cell lymphoma. And this important cytogenetic abnormality called DUS22 is seen in 25% of cases. A quick review of the definitions on WHO hematology. Cutaneous ALCL is composed of large cells with anaplastic, pleomorphic, or immunoblastic morphology. Vast number of cells show CD30 positivity. T cell markers are positive. MUM1 is also positive as described in the WHO book, and ALK is negative. So, on all these aspects, our case satisfies the required criteria. However, lymphomatoid papulosis is just a benign end of this spectrum. Primary cutaneous ALCL is treated with chemoradiotherapy. Lymphomatoid papulosis is not. So the take-home message in this case was no, it was not given as just a rare diagnosis. It was actually given to help you all approach an undifferentiated malignant tumor. So you initially studied the slides without any clinical info, then add the clinical info, make a top DD 1 to 3, and then use lineage differentiation markers as the first line of markers. Come to one of those boxes, check boxes, and further go ahead with the specific markers mentioned in those check boxes to give to add the secondary line of markers, and you come to an accurate diagnosis as we've shown in our case. And this is the reference article I've been putting, Archives of Pathology of Law and Lab Medicine, December 14 issue. Any questions, please? Yes, ma'am. So that is yeah, I agree with the significant myxoid component in the back. Yeah, it was supposed to be a googly case. So, yeah, I agree with the important finding of a myxoid stroma in the background. In fact, variants which have been described as myxoid cutaneous ALCL also have been seen in the literature. They've been quoted. There are rare case reports of such tumors. So, thank you very much. Let's go to the next case. Case number 5 would be discussed by Dr. Shushruta from MIMS, Mandya. Sorry to take. Pointer. Yes. Also the pointer or this also?
Good afternoon, everyone. Myself, Dr. Sushita
from Mandya Institute of Medical Sciences, Mandya. We got a case of 35-year female, resected small segment. On the scanner view, we could make out the fragment of small intestine with mucosa, submucosa, muscularis propria, and serosa. And mucosa displaying weakness, atrophy, and mucosal ulceration with focal area of necrosis was noted. On the higher view, again, we can make out the areas of necrosis and mucosal ulceration with many dilated lymphatic channels and congested blood vessels within the submucosa. Again, higher view showing many dilated lymphatic channels and congested vessels with many inflammation infiltrates, composed predominantly of lymphocytes, plasma cells, and histiocytes were noted. The view showing many congested vessels and, as I mentioned, chronic inflammatory cell infiltration in sheets with histiocytes. We could also make out few of the cells which were enlarged with cellular megaly and as well as nuclear megaly was noted, which was most commonly seen within the stroma and also surrounding the blood vessels, that is involving the endothelial cells. Higher view again, few cells which are massively enlarged surrounding the endothelium. These individual cells showed intranuclear basophilic inclusion with a halo surrounding it and also small granular inclusion in the cytoplasm. This is the higher view. As we can make out the basophilic inclusion in the nuclei, the halo surrounding it, and the cytoplasm also showing few granular inclusion. So to summarize, it was a section from small intestine displaying mucosal ulceration with focal areas of necrosis, with viral inclusions noted within the stromal cells as well as in the endothelial cells. The affected cells showed intranuclear basophilic inclusion and as well as intracytoplasmic granular inclusions. So we came to a diagnosis of cytomegalovirus enteritis. Thank you.
Very good presentation, Dr. Sushruta. Now I invite Dr. Ranjana from our lab to discuss this case in detail.
Thank you, sir. Here, this patient was a 35-year-old male patient, presented to us with fever, abdominal pain, vomiting, and past history of renal transplant. This is the scanner view, and it shows a segment of colon. Sorry for the history. There was a typographical error. It was a resected segment of bowel. So this is the segment of colon showing depressed ulcer. And this is a low power view wherein you can see the ulcer base and underlying granulation tissue. So when we go to a high power view, we can see few large cells showing eosinophilic inclusions. These inclusions had halo around it and surrounded by a granular cytoplasm. We can see this even in the endothelial lining. So this is another picture showing cytopathic changes in the endothelial cells. Can be seen within the endothelial lining and as well as in the stroma. Stroma also you can see these cells. And here is one more infected endothelial cell causing vascular occlusion and thrombosis, so thereby leading to ischemia and ulceration. So this is the picture taken from the non-ulcerated area, wherein these cells are also seen in the lamina propria.
Here also we can see these cells and thrombosed blood vessel and chronic inflammatory infiltrate. The endothelial cell, infected endothelial cell. The diagnosis is, she rightly said, CMV colitis. So to support the diagnosis, we performed immunohistochemistry for CMV and polymerase chain reaction for CMV DNA, both of which were positive. So you can see the cells which have picked up the stain. This is the endothelium, which shows positivity. This is from the non-ulcerated area, which shows the positive stain for CMV. CMV virus belongs to the family of herpes viridae. It is a DNA virus, and man is a natural host. It's most commonly seen in immunocompromised individuals, in transplant recipients, in pregnancy, and due to excessive use of immunosuppressive drugs. The commonest sites include colon and esophagus. Coming to pathophysiology, after the primary infection, the CMV infection remains latent, and macrophages serves as infection reservoir in the latent period, which results in reactivation at a later date, especially in immunocompromised individuals. Complications include ulceration, perforation, peritonitis, and death due to GI bleed. And mode of spread is usually direct contact with body fluids of infected person through breast milk, through blood transfusion, organ transplantation, and even transplant. Microscopically, these infected cells show cytomegaly with basophilic intranuclear inclusions called powdery bodies surrounded by clear halo resembling outer dye. And these are most predominantly seen at the ulcer base and in the endothelial cells and mesenchymal cells, which results in submucosal vasculitis, thrombosis of microvessels, and necrosis. To support the diagnosis, we can perform immunohistochemistry for CMV, PCR DNA amplification. Detection of viral mRNA coding for PP67 protein is done to quantify the CMV viremia. Differential diagnoses include inflammatory bowel disease and ischemic colitis. So it's very important that we look for these viral inclusions before signing out. Coming to the prognosis, even though the clinical manifestations are aggressive, if treated early, it shows a good prognosis. Thank you. Any questions? Thank you.
Thank you, Dr. Manipal. Very quickly, we will move to the next case. That is case number 6, to be presented by Dr. Ronia from MPG Medical College.
Good afternoon, everyone. I'm Dr. Ronia Francis from MPG Medical College. The history given is a 39-year-old male with a sinobasal mass tumor, which is infiltrating which is from the nasal cavity as well as in the sinuses and in the turbinates. So this is the whole mount view of the tumor mass, in which you can see there are multiple fragments. And you can see in this mass, it has an epithelial lining, and we have a subepithelium which is containing a hypocellular area, and below that, well demarcated area of the tumor, which does not have any connection with the epithelium, and the tumor has blood vessels, dilated blood vessels, as well as adipocytes, and there are large areas of hemorrhage. And epithelium in higher order, it is respiratory epithelium, and it shows squamous metaplasia. And the subepithelium has this hypocellular area which was seen in the scanner. It was containing fibroblasts, and below that, this well demarcated tumor with adipocytes as well as blood vessels. And this is the interface between these two areas. And this
This area contains fibroblasts as well as lymphocytes and many minute blood vessels. And on studying further, we can see many blood vessels, and these blood vessels they lack the normal architecture. That is, it is not having the muscle layer, and there were many areas containing extravasated hemorrhage and RBCs. And the tumor cells, they are arranged in a patternless pattern around these blood vessels. And individual cells, they are spindle to ovoid with round to oval nucleus. And coming to this nucleus, they are bland looking, and they have a very regular nuclear membrane, and there is no nucleoli. As well as there is no areas of necrosis, and there are no areas of areas showing atypical mitosis. And there were few vessels which were, many vessels which were ectatic, and few vessels showing perivascular hyalinization, and many areas with hemosiderin-laden macrophages, and a few areas showing adipocytes. Coming to the summary, we have a young male presenting with a nasal mass, infiltrated based on history. And the histopathological features, it was a submucosal tumor which is well demarcated without any connectivity with the epithelium. And it is a cellular tumor with many ectatic vessels. And the tumor cells were arranged in a patternless pattern around these vessels. And few of the vessels were showing perivascular hyalinization. With these features, I'm giving my first diagnosis, differential diagnosis as glomerular pericytoma. And my secondary will be solitary fibrous tumor. But in solitary SFT, there will be rubic keloidal collagenous bundle, and there is a collagenous stroma. And the third DD will be hemosiderotic fibrohistiocytic lipomatosis lesion, but this is a very rare case, and the site will be usually in foot and ankle. Coming to IHC, glomerulonephritis, the positive IHC will be actins, and it will be positive for nuclear beta catenin, which will be negative in case of SFT, and SFT will be positive in STAT6 and CD34, while it is negative in case of glomerulonephritis. Thank you.
Thank you, Dr. Romia. Now I invite Dr. Abhijit from our department to present the case in detail.
Good afternoon. So this is case number 6. The history provided was a 39-year male patient who presented with a sinonasal mass involving left posterior ethmoid sinus, left frontal sinus, and middle turbinate of the left nasal cavity. A brief history of this patient before this actual presentation. He had a history of fall 1 year back, which resulted in multiple fractures involving thoracic and lumbar vertebrae. Since then, he's complaining of increasing pain, muscle pain, and bone pain, and inability to perform daily routine activities such as climbing stairs, getting up from the chairs, and he experienced considerable hand pain while lifting heavy objects. So clinicians thought of osteoporosis, but that was DEXA scan was done, which was not suggestive of osteoporosis. Uh, Serological and biochemical investigations revealed persistent hypophosphatemia over a long period of time. However, his 24-hour urine phosphorus levels were within normal, as were serum calcium, sodium, potassium, and chloride levels. Serum creatinine was also normal, thereby ruling out any renal diseases, which is the cause for this hypophosphatemia. So the clinicians, they have a preliminary diagnosis of osteomalacia, which is nothing but delayed or inadequate mineralization of mature osteoid that leads to bone pain, muscle pain, etc. So considering these findings, they went ahead and did FGF23 level, which is a known phosphaturic hormone, and they found that the levels are markedly elevated in this patient. So they had a preliminary suspicion preliminary diagnosis of oncogenic osteomalacia. Therefore, they went ahead and did Dotonov PET CT scan, which showed an increased somatostatin receptor expressing lesion in the left nasal cavity, thereby confirming their clinical suspicion, that is oncogenic osteomalacia and tumor-induced osteomalacia, which is nothing but a paraneoplastic phenomenon in which any malignant neoplasm, either epithelial or soft tissue neoplasm, which is associated with the osteomalacia. Subsequent ENT examination revealed a pink fleshy mass in the left nasal cavity, for which the patient underwent paste surgery. And the tissue was received in multiple fragments, and this is one of the representative low power photomicrographs on the slide which was provided. Here we can see that the tissue fragments are in small pieces, focally covered with the respiratory lining epithelium with focal squamous metaplasia. And the main tumor is in the subepithelium with no connection to the overlying epithelium. The tumor is composed of different elements. At this field, we can see that there are numerous blood vessels of variable sizes. There is this area which is showing spindle cell proliferation, and there is a good amount of adipose tissue. This is a higher magnification where we can see that there is a respiratory lining epithelium and there is a moderately cellular proliferation of spindle-shaped cells in a well-vascularized stroma, which is composed of many large, thick, dilated blood vessels with muscularized wall to small capillary channels. And at uh, focal areas, they showed this arborizing and branching hemangiopericytoma-like blood vessels with large areas of hemorrhage that resulted into many scattered hemocysteine-laden macrophages. Focal area showed microcystic appearance within this stroma that may have resembled like a capillary hemangioma-like appearance. The spindle cells were embedded in a loose fibromyxoid background, which was not very well appreciated in this slide which was provided, but at other places that was very classical, and some in some other slides that had a immature osteoid to immature chondroid-like appearance, and focal area showed calcification within this chondroid matrix material. Coming to spindle cells, these were moderately cellular proliferation of spindle cells. The cells had an oval to elongated spindle-shaped nuclei with uh, bland nuclear chromatin, inconspicuous nuclei, and scanty cytoplasm. The mitosis was not increased and there was no significant necrosis. These spindle cell areas were intimately admixed with mature adipose tissue, and focal areas showed scattered as well as small collections of osteoclastic type of giant cell. So taking into consideration all the histological features as well as the clinical history of this patient who had osteomalacia with persistent serum, low levels of serum phosphate and elevated FGF23 levels, the final diagnosis in this case was a phosphotic mesenchymal tumor which is causing tumor-induced osteomalacia. So, phosphatic mesenchymal tumor is quite rare with only roughly 450 cases reported till now. The first case was discovered way back in 1950, but only recently it has been included in the WHO classification as a distinct tumor entity. It commonly affects middle-aged adults with equal sex prevalence and median age being 52 years. It can occur at virtually any soft tissue or osseous location. The commonest bony locations include appendicular skeleton, cranial bones, and bones of the paranasal sinuses, like the current case. And soft tissue sites of involvement include mainly distal extremities and acral side. The tumor may remain occult for a long time before it is detected clinically or radiologically, and the main presenting symptoms of the disease are mainly due to persistent hypophosphatemia, which result in increased muscle pain, bone pain, and progressive weakness, which may last for months to years. In a recent large study from China, they have noted that the average duration between onset of symptoms to the clinical diagnosis of tumor-induced osteomalacia was 3 years, and that from initial presentation to complete resection of tumor was around 5 years. So these patients will have an indolent course with morbidity, which is mainly related to persistent hypophosphatemia. As the disease progresses and as tumor size increases, there will be increased production of FGF23, and that leads to increase in bone pain, muscle pain, and fragility fractures in multiple bones. The main pathogenic mechanism of this disease is due to overproduction of FGF23 by the tumor cells, which is a phosphatidylcholine hormone that is normally secreted by osteocytes and osteoblasts. This hormone, it acts on the proximal renal tubular epithelial cells via FGFR1 receptor, and it causes internalization of sodium phosphorus co-transporter, thereby reducing reabsorption of phosphate from the proximal renal tubular cells. It also inhibits the final enzyme that is that involved in conversion of active form of vitamin D. Therefore, that further reduces intestinal absorption of phosphorus. Therefore, FGF23 levels can be used as a serum tumor marker for diagnosis of this tumor as well as monitoring post-surgical tumor recurrence. Since the tumor may remain quite small in the initial phases, therefore it may not be detected either by clinical examination or conventional radiological investigations. Therefore, radionuclide scans are preferred modes of treatment that will show increased tracer uptake at the soft tissue or bony location. And 68 gadolinium prototype PET CT scan is considered to be highly sensitive for its diagnosis. Immunohistochemistry has a very limited role in the tumor diagnosis. Mainly, the diagnosis is based mainly on constellation of histological features in an appropriate clinical background of tumor-induced osteomalacia and persistent hypophosphatemia. However, the tumor cells are positive for non-specific markers such as vimentin, SAT-D2, CD56, ERG, and somatostatin receptor 2A, with variable positivity for other markers. And recent studies have found that most of the around 50% of these tumors they harbor translocations involving fibronectin 1 gene, the fusion partners being FGFR1 and FGF1. The differential diagnosis that depends upon the tumor location. In the sinonasal location, the differential will include solitary fibrous tumor, sinonasal glomeruloperiscytoma, nasopharyngeal angiofibroma, and giant cell tumor of soft tissues. While in osseous location, differentials include giant cell tumor of bone, non-ossifying fibroma, and aneurysmal bone cyst. Previous studies, either as a case report and small studies, have noticed association of tumor-induced osteomalacia with all these tumor entities. But many authoritative figures in soft tissue pathology believe that those all cases were actually misdiagnosed phosphatidylcholine mesenchymal tumors because the tumor closely mimic these differential diagnoses. So that's why we have to correlate these histological features with the clinical presentation and laboratory investigations. Coming to prognosis, overwhelming majority of these tumors are benign in histology and they pursue a benign clinical course with complete resolution of hypophosphatemia and osteomalacia once the tumor is resected. But if the tumor is incompletely excised, then there are high chances of tumor recurrence. A few case reports of malignant phosphatidylcholine mesenchymal tumor have also been reported. These tumors will show high-grade sarcomatous like morphology or pleomorphic sarcoma like histological features, but they will in addition contain areas which resembles benign phosphatidylcholine mesenchymal tumor, or these patients will have previous history of benign PMT. And patients with malignant PMT will pursue aggressive clinical course with increased chances of distant metastasis and poor prognosis. Coming to a brief follow-up of this case, the patient immediately after surgery, his serum phosphorus levels became normal and he had marked symptomatic improvement in the symptoms. Only occasional pains are seen in the lower limbs and recent FGF23 levels, which was done post-operatively, has also been normalized. So this is a classical case of phosphatidylcholine mesenchymal tumor. This case was just kept to make people aware about this tumor entity, and any case with tumor-induced osteomalacia who has a tumor in the either soft tissue or bone, one should think twice before diagnosing it as any other tumor entity than phosphatidylcholine mesenchymal tumor. Thank you. Any questions? Okay.
Thank you, Dr. Abhijit. I call on Dr. Ashwati Pradeep from KCIAPM Medical College present the seventh case to us. So, I'm sorry for the interruption. Let's go ahead with case number 7 to be presented by Dr. Ashwati Pradeep.
Good afternoon. I'm Dr. Ashwati Pradeep, final year postgraduate from KCIAPM Medical College, and I'll be presenting case number 7. So the history given to us was of a 15-year-old female left pneumolectomy specimen. So you can see normal lung tissue and a well-encapsulated, well-circumscribed tumor tissue. Again, normal lung tissue. So you can see diffuse sheets of tumor cells and some vascular spaces, staghorn-like vessels. So you can see round to oval cells, some spindle cells, and some pleomorphic cells. You can see some spindle cells and some vascular spaces. Also, they have pale eosinophilic to clear cytoplasm, and few mitotic figures can be seen. So again, vascular spaces can be seen. Plenty of staghorn-like vessels are seen with hematopoietic pattern. So sometimes in the microscopic findings, it's a well-circumscribed, well-encapsulated lesion, diffuse sheet of cells, round to oval cells, spindle cells, and few pleomorphic cells are seen. Pale eosinophilic to clear cytoplasm, prominent nucleoli, plenty of vascular spaces, staghorn vessels. Imagine peristatic pattern is seen. 3 to 4 mitotic figures are seen per 10 hyperfields. So my differential diagnosis is synovial sarcoma, metastatic or primary, thymoma type A, very intrapulmonary, solitary fibrous tumor, small cell neuroendocrine carcinoma, and metastatic endometrial stromal sarcoma. So in synovial sarcoma, the points taken are ovoid to spindle cells, imagine metastatic pattern and pleomorphism. Points against are rare at the site. Confirmation can be done with cytogenetics, Vimentin, CD99, ECL2, S100, S100, CD56, and TLS1. Type thymoma is a well-circumscribed tumor, hematopoietic pattern, spindle to oval shaped cells. It is rare at this site. CK confirmation with CK19, CK10, and CK20. Third differential, solitary fibrous tumor, spindle cells are seen, hematopoietic pattern, patternless pattern, and malignant solitary fibrous tumor. It points more towards it because there are more than 3 to 4 mitotic figures per 10 hyperfields. Cells separated by hyaluronized collagen is absent. So that is a point against it. Specific for this is nucleus STAT6. Small cell neuroendocrine, the site, it is a very common site, lung, and ovoid to spindly cells are seen. However, staghorn cells are unusual at this site in neuroendocrine, and nuclear molding is absent, and dense chromatin is present instead of the salt and pepper chromatin in neuroendocrine. Confirmed with synaptophysin and chromogranin. Endometrial metastatic ESS features pointing is that it is a female, and lung is a common site for metastasis. Ovoid to spindly cells are seen, but history is not provided, so that we cannot confirm it's that differential. So can be confirmed with ER, beta catenin, cytokeratins AE1 and AE3. So my first three differentials are synovial sarcoma, type A thymoma, and solitary fibrous tumor malignant.
Thank you, Dr. Ashwati. Now I invite Dr. Sushmita from our department to present case 7 in further detail.
This case presented to us was a 58-year-old female with lung cancer. And this patient had a history of 10 years of being treated with breast carcinoma. And we had got first sample was core biopsy sent from our Whitefield Manipal Hospital. That time we were very confused with the diagnosis because it was core biopsy and very limited. It was about a zero 0.8 into 0.1 size codes. Later we had got the resection specimen for this case. So the first core biopsy we had seen, it was a similar morphology, but the case was difficult. It was very limited tissue, very small tissues, and also there were admixed with fibrin. And we had done a battery of IHC for coming to the diagnosis of this test. So only because of that interest, suppose if we get core biopsy and we get a limited tissue, how to come to the diagnosis? Because once in the multi-specialty hospitals, we don't get the resections first. We first get the core biopsies, and nowadays it's a needle core biopsy coming into play. Every practice you go, you will always get needle core biopsy, which is coming to you, and then you have to judiciously use the IHCs. Because we cannot randomly use a 10 or 20 IHCs, because every IHC we learn or we run, we have to tell the consultant why we are running even one extra marker, because every marker is cost for the patient and also cost for the package for which the patient comes. So we have to always judiciously use the IHC markers. For that approach, we have kept this case. And the resection specimen we got after we got the confirmation of the diagnosis. Because once we definitely give the diagnosis, then depending on that, the treatment will be taken up by the consultants, like the surgical onco group. So as very well described by the PG who was presented, that it was showing a very cellular and pleomorphic neoplastic lesion, which was having this hyalinized hemangiopericytoma-like blood vessels which are intervening these beta cells. And mitosis in some areas were very high. Along with that, in the resection specimen, we got areas of necrosis. Now, as I told, we got the core biopsy first. How did we go about it? That is because it's a female patient with a known history of breast carcinoma. The clinician wanted us to rule out that whether it was any metastasis from the previous known case of breast. For that, we had run the first line of 4 biomarkers, that is CK, just to confirm whether there is any carcinoma metastasis. We did a GATA3, which will be also positive for breast metastatic deposits. Then we did a ERPM. As rightly she has told, if it was an ESS, ESS will also be having ERPM positivity. But for that case, what we have, we will be having multiple deposits, especially in the endometrium, cervix, in parts of the peritoneum, and also there will be history of this extensive lesion. But here the lesion was localized only to the pleural. It had been represented as a pleural mass, pleural base mass. So that will also we didn't think of an ESS in the first go. Then when these markers came positive and it was in the morphology mostly sphygmoid cells, we went to the second line of IHC. That means it is not from the first metastatic case of a known breast carcinoma. So it will be a new primary which is there. So when it is sphygmoid cells, what we do, we just run the protocol of the basic markers just to see which lineage it is first. Because that way we can tell, the clinician or the oncosurgeon that this is the way to proceed forward to. Now we had run just to see whether it was a leiomyoma or a leiomyomatous lesion in leiomyocytes. For that we had done an estimate estimate. Those were negative. S100 was also negative. CD99 was negative.
Rather, all the markers which we ran for this case was negative, and only one thing which was positive was it was a very proliferative tumor, so it was having areas of variable KI index like 40 to 60. So that way it does help us to tell that okay, this is a malignant lesion. Then when all these markers were negative and we were also thinking morphologically that it could be synovial sarcoma because that is what in the longest lesion that comes more commonly, and when we have this battery of IC is coming negative, so then the next like thing what we have in our hand was to put one more marker to confirm whether it's a synovial sarcoma or not. So for the third line we had put for TLE1, which is one of the latest marker and very specific for that. And to our surprise or to like eventually it helped us a lot, the TLE1 was diffusely positive. Because you know we are always answerable. We have to answer, we have to tell that what lesion they have sent is. We cannot tell that we cannot tell you the diagnosis, everything is negative. So we have to go on hunting and there is an answer and we have an IC to demonstrate that. So for our lab, and theory was diffusely positive and also morphology was supportive of that. Because IC if it is positive and morphology doesn't support, then also we have to go back and relook at our morphology. So microscopy she has already described as this spindle-wide oval cells. And here you can see brisk mitosis. When we had counted 10 fields, it was nearly 30 to 40. In the next hyper view, you can see the spindle-wide cells with pleomorphism. And in this one, you can see areas of necrosis. So areas of necrosis, pleomorphism and mitosis always point towards high-grade sarcoma. And this is a TLE1 which is diffusely positive. So now let us come to the mesenchymal tumors of lung, which is the outdated 2015 pathology classification, where it is being categorized into four different sections. First one, vascular tumors and vessel associated tumors. Next is non-vascular spindle cell tumors. Third, other mesenchymal tumors and tumor-like lesions. And the fourth one, the pediatric tumors, metastatic mesenchymal tumors. Now, when we saw our case, it definitely did not fall into the first group. It is not a vascular tumor. So, it is in the second group, which is non-vascular spindle cell tumors. So, also we could, as we saw the diagnosis of the first with the IC, we could bring or not sort of limit ourselves that it could be in this non-vascular spindle cell tumors with 3 DDs, that is, we should exclude an SFT, IMT or a synovial sarcoma. So the different DDs which we should consider before putting the biopsies, because of this varied morphology, we really nowadays it's so away. It's become such a broad spectrum that we cannot just rely on the morphology as before. We have to give definite diagnosis and support our morphology depending on the IHC confirmation, because the surgical intervention and the further treatment will be based on the confirmatory diagnosis which we give. Not only because for the clinician, also because of the medical legal issues which come up. So for every diagnosis we give, we have to have a supportive IHC marker to support the diagnosis. And now for the intrapulmonary solitary fibrous tumor, it was previously known as the hemangiopericytomas, belong to the class of fibroblastic tumors that it's very rarely seen in the lung. SFTs typically develop in the pleura as well as in the extrapulmonary organs. Histologically, SFTs are very classical. They will be having those hypocellular and hypercellular areas with prominent collagenous fibers. So that pattern was lacking in this lesion. So first, on the morphology, we didn't consider this. Now, on IFC SFT, there is a like specific marker in slum, that is STAT6, which we had run for this case also first on the core biopsy, because it was a core biopsy. We didn't have the resection in our hand. So STAT6 was negative. If you could recollect, it was negative in the run of the panel of the IHC, which we had done in the second IHC panel.
Now, expression of STAT6 results from NAV2 STAT6 fusion gene, which is specially and specifically observed in the SFGs. The fusion gene involving STAT6 and the subsequent expression of STAT6 protein are characteristically observed in SFGs and serve as reliable diagnostic markers. Now next, which we wanted to explore was IMT, but here also IMT is where the age did not correlate for IMT, and it mostly develops in abdomen and pelvis, and occasionally and rarely in the lung. IMTs are composed of abundant inflammatory lymphoplasmacytic cells. So, and when we see the spindle cell arrangement in IMTs, they have a fascicular pattern, and in between we see dense lymphoplasmacytic cell arrangement. Here also we didn't see the pattern which is rich in lymphoplasmacytes. It was only sheets of spindloid cells which was atypical. So morphologically also our slide or morphology does not support IoT. And IoT as such does not have any specific marker, but ALF is being done in most cases because if ALF is positive, it depicts or helps us to tell how aggressive IMTs can be, and IMTs which do behave aggressively or recur are known to be positive for ALF. So ALF is helpful in the diagnostic and therapeutic purpose. Now coming to synovial sarcoma, which is our case, it usually arises in soft tissues and extremities, and lung is one of the most common organs in which we can see synovial sarcomas, and also it is the site where they metastasize also. And according to the morphology, with the epithelial and with stromal differentiation, they have been morphologically subtyped into three groups, that is monophasic, biphasic and poorly differentiated. Most of these pulmonary sarcomas belong to the monophasic and poorly differentiated subtypes. Now, pulmonary synovial sarcomas are frequently seen exhibit a poorly differentiated morphology and undergo very aggressive forms compared to soft tissue synovial sarcomas. They stain mostly for CD99 BCL2, but these markers are not specific because in many of these soft tissue sarcomas, we will see BCL2 and CD99 positive. Synovial sarcomas can also take epithelial marker positive like CK and EMA. And recent marker, which is GLE1, is very specific, and that helped us to come to our diagnosis. Cytogenetics, it is genetically X18P11Q translocation, which leads to an XYT fusion. Is considered to be specific translocation that is diagnostic of synovial sarcoma by FISH or RT-PCR. Recently developed vaccine therapies have been seen to be of efficacy for SYT-SS exclusion gene, and this SYT-SS exclusion gene may serve as a companion diagnostic marker for these tumors. So our diagnosis was pulmonary monophasic synovial sarcoma. The patient had been treated with posterolateral thoracotomy, left radical lymphadenectomy and partial resection of diaphragm and pericardium. There was no lymph node metastasis, and the patient is under follow-up and doing good. Till date, there is no metastasis, no history. And I have seen the clinical details also. Patient is doing good with any metastasis. Thank you. Any question?
Thank you, Dr. Sushmita, for the lucid presentation. This sudden change in the game plan, as the proceedings were getting a little monotonous, we plan to introduce a spotter session now, which will be a mini quiz, which will be conducted by Dr. Kushbu. We have a set of 10 cases broken up into two segments. The first installment of 5 cases will be dealt with now, and then we'll go back to the cases which which had gone online. And then we'll come back to the spotters again, to the remaining cases within the spotters. Now the rules of the game are, Dr. Kushbu will be asking a question, showing you a slide, and there will be questions based on that. So people with the answers can just raise your hands, and we'll come around with the mic and give you the mic so that you can come with the diagnosis. So Dr. Kushbu will be waiting for about 5 to 10 seconds uh, to expect an answer from you guys. So yes, handing over to Dr. Kushbu.
And yes, the person giving the right answer will be provided with chocolate. So coming to case number 1, there was a 57-year male who presented with GI symptoms and upper GI endoscopy showed nodular thickened dural folds. So this is the representative microphotograph from the journal, and this is the higher magnification. Here can you see in pathology? Lines appear normal, something in the reporter. Please raise your hands. Please raise your hands. Otherwise, there is only finger chocolate. Yeah. Yeah, correct. So this is the additional step.
Sorry.
Okay. Thank you. Now this is the additional step. Here you can see the pH MRI is fast negative and the component is positive, and it showed apple-green bias changes under the polarizing light microscope. So the diagnosis of neurodermatitis. Now quickly moving on to case number 2. Here the 25-year male from Africa presented with hematuria on cystoscopy. It showed shanty granules on the floor and the posterior wall. So this is the representative microphotograph. Here you can see that there is urothelial lining. And can you see here, appreciate something? Higher magnification. Higher magnification. Chocolate is lost because there are too many candidates. Please raise your hand because there is a mistake in chocolate. So these are so here these are the tests of the cystosoma. So third case, 40-year who was a renal transplant patient on immunosuppression presented with fever on lower GI endoscopy. Mucosa showed yellowish mucosal patches and seen in the ascending as well as the transplant column. Presented in low power microphotograph. Here you can see the ulcerated epithelium and the lamina propria is expanded. Higher magnification. So the skin cells tissue size. And here's something. Please raise your hand. Will come with the mic. Yeah, correct. So this is the targetoid appearance of the myelin segment body. So it was the malaxia of the colon. Now moving on to case number 4. With the 12-year child is presented with multiple domes with skin nodules in central umbilicus. I think that was pretty straightforward. That was really spotted. So that's all. So now moving to case number 5, there are 65-year male with positive patient presenting with dysphagia. Clinically, candidiasis was suspected and extrapigial biopsy was performed in this patient. This is a representative photograph. Here you can see ulceration, higher magnification. Please raise your hand to your person. Yeah, correct. This was the case of expensive. We'll stop now and now continue with the cases. Rest of the 5 spots will deal at the end of the session.
So, thank you, Dr. Krishnu. Hope you all enjoyed these cases and are more attentive now. We'll get back to our main seminar. We'll now move on to case number 8, which will be presented by Dr. Richa from St. John's Medical College.
Good afternoon to all. I'm Dr. Richa from St. John's Medical College. The case that was allotted to us was case number 8, which came with a history of a 58-year-old female who presented with multifocal heterogeneous hypodense lesions in both lobes of the liver. When we saw the lesion, it was a linear flow biopsy of the liver, which showed tumor, which was arranged diffusely in sheets. These tumor cells had a clear cytoplasm, and on going higher, these tumor cells had a clear cytoplasm, as I told. Some of them also had a eosinophilic type of cytoplasm. The nucleus was hyperchromatic, and focally, some acinar pattern as well as the arrangement of these cells around vessels was also noted. Few of these cells showed some eosinophilic nuclear inclusions, and many bizarre cell forms were noted. There were also foci of necrosis, but the adjacent liver, which was in the biopsy, showed no cirrhotic changes. There were just micro and macrovesicular steatosis. So to summarize, it was multifocal lesions in the liver, which was non-cirrhotic. The cells were found to be arranged in sheets with occasional acinar pattern, with hyperchromatic nuclei and moderate amount of clear to eosinophilic cytoplasm. Multiple foci of necrosis were noted. So the first differential that we had was a metastatic carcinoma, which morphology-wise could most probably be of a renal origin. And if we consider the incidence could be also of a colorectal origin, which is the most common primary for a liver mets. The other TB that we thought of was a multicentric clear cell hepatocellular carcinoma. But since the liver is non-cirrhotic, it is very rare to be a HCC. Thank you.
Thank you, Dr. Richa. Now I invite Dr. Sushmita back to discuss this case in detail.
Case number 8, we had got a liver core biopsy, which presented the patient had presented with large enlarged liver nodule and also had multiple lung nodules, which were smaller in size. And this largest of the liver nodule, which had been seen and taken the biopsy from, was 11.8 to 8.5 to 6.4. And the clinical suspicion from the clinical side was to exclude an HCC or also metastasis. Alpha fetoprotein level was normal and CA was also low within normal limits. Now, as she has described already, we could see this cause of liver parenchyma infiltrated by sheets of this round tuber cells with hyperchromatic nuclei. Some of these cells did show eosinophilic macronucleoli. Still, we are in a dilemma whether HCC or metastasis. Now, this is a local view. We have the 20th view. Some more higher power view. 40th view with this large cell with macronucleoli, eosinophilic macronucleoli. This cell here, here. Any guess at this point? Okay, next slide. You can see this macronucleoli here also. And then on further searching, we can see these atypical cells with coarse brown granules in the cytoplasm. Yes, it is a melanoma. But seeing on scattered cells, it is very difficult to find and appreciate.
And as my colleague already had described the approach to carcinomas of unknown primary, we also have done a similar approach pattern as I had discussed with you all before. We take step by step every IC we have to plan and judiciously apply. Even here, according to this flowchart, we also had followed, we have a protocol here to follow. Like first we exclude metastasis of for this unknown origin. We will first exclude whether it's from lung, colon, and then we go to exclude whether it's whether it's a melanoma or then lymphoma and lichen. So this is the first marker which we use. Is very useful for us and also when you will be practicing. It is 7 and 20. 7 positive and 20 positive are mostly in the upper GI tract, pancreas, biliary tract, and mucinous carcinomas ovary. Once this is positive, then we have to do a 19 and CDX2, which guides us through whether it's a biliary tract or ovarian or upper GI. And if it is CK7 positive and 20 negative, then it can be thyroid, lung, breast, so on and so forth. So I think I will leave the flowchart here only and go to the next. Because already I think Dr. Anand has shown in the previous case of the skin lesion. So once we are done with the epithelial markers, if they are all negative, then we, according to our protocol, as I have told, we want to exclude the colon and the GIT first. So I'll just tell you that. So 720 will help us regarding that. After that, we put a TTF1 to exclude whether it's a lung, thyroid, and when these are also not helping us much, then we go and put both PSA, melan, S100, and the other markers. So in our first panel which we used for this case, as I was telling you, it was CK7, 20, CTX2, CK19, C19.9, and which are all negative. So it is not a metastatic tumor which is coming from the upper GI or pancreatic biliary. The surgeon and the clinician, treating clinician wanted us to exclude an HCC. So we have used heparin arginase, which both were negative in this case. Then we also had put the second line where we wanted to exclude the neuroendocrine tumors. So because of the nesting pattern, if you see in the lower part, the tumor is arranged in nests and pods. So we have used a cyanotophysine and chromogranin to exclude whether it's a neuroendocrine tumors or not, because the treatment will change. Here, whenever we practice, we use this IC panels in bulk because we will just first want to tell the clinician whether it's from lung because the treatment will be different for that. Then we want to exclude whether it's a colon, upper, lower, or pancreatic. So we use a bulk analysis for that, like CK7, 20, CK19, 19.9 and CBX2, and then we also exclude neuroendocrine cancers and neuroendocrine tumors, NATs. For that we use cyanotophobos. So as the treatment protocol changes, so we define or we judiciously apply the IC markers accordingly. And then we had also used SATB2 for now, we have used a TTF1 which is negative, CD10 negative, PAX8 negative to exclude whether it's from ovary mass or not, and LCA to exclude whether it's a lymphoma. So till now we didn't get any answer. So we have put the third line of IC. Then we have put the third line of IC to see whether it's positive for melanocytic markers. See, substance is positive, S100 positive, HMB 45 positive, and KI 67 is about 40%. So, as I agree with you, in the core biopsy, we don't see many cells with the brown pigmented cells. It was only one or two, so it was very difficult to make the decision. It is with IHC which really helped us at the confirmation that what we were seeing on the morphology is not hemosiderosages, but it is a melanoma and that pigment deposition. So always the morphology when we are practicing, we cannot give the diagnosis. As I was telling in previously also, we have to be backed up with the ICs. So with the IC helped us to confirm our diagnosis. So this was the positive IC markers, S100,
previously positive, you can see the HLA45 and soft positivity. So the liver nodule which we diagnosed was melanoma. We had also spoken to the oncology group, surgical oncology, and the treating oncologist, whether the patient had any other cutaneous lesions or any other lesions elsewhere. But they told no, the lesion was confined to the liver only with small nodules in the lung. So mostly we are dealing with a primary malignant melanoma of the liver, but it is very rare. Very few cases have been reported till date. I think literature tells maybe 4 to 5% only of primary liver melanomas. Melanoma is a like melanin producing tumor, and most of it we see in the above, like in the fourth decade, fifth decade, above the third decade. It occurs mostly in the skin, which is like we found, which is found in the retina, endometrial, then genital tract, GIT tract, accessory nasal cavity, and parotid. Because this is a middle-aged patient, we had asked the clinician repeatedly to search for whether there was any anorectal canal growth or skin lesions, but they had confirmed that the patient did not have any other lesions elsewhere. And non-cutaneous primary melanomas carry a very high mortality because of their propensity for dissemination and invasion, often before they are even clinically accurate. Primary malignant melanoma of the liver is extremely rare, non-epithelial neoplasm, and I was telling you it was very few cases. This is the references. And this case, I think is the patient was very sick, and we have lost the patient for follow-up. They were not from Bangalore, they were from West Bengal. They were gone back because the patient were deteriorating fast with the disease burden. Thank you. Any question? And this is our team, where you can see this is Dr. Anjana. Kushbu maybe was taking the picture, so she's not here. This is Dr. Abhijit. This is Dr. Kiran, one of our nephropath doctors. And this is Dr. Anand. This is our technical team, and they are always doing wonderful sections, as you may have seen, and always help us whenever we ask them to. So I always thank them for their support. Thank you.
Thank you, Dr. Sushmita. Thank you for the warm introduction again. Now we'll move on to case number 9. It will be presented by Dr. Amritavani from Aditya Institute of Medical Sciences.
Good evening, everyone. I'm Dr. Amrita from Aditya Institute of Medical Science. We got our institute got the case 9. So history given was 41-year-old female with clinical diagnosis of transitional cell carcinoma, urinary bladder, and transurethral resection of bladder tumor was done. And on section fragments of bladder mucosa are seen with fragments showing transitional epithelium with submucosal showing mild congestion and muscularis tissue and muscularis tissue few cochlear glands are seen. And this is the hyperview of the your transitional epithelium. And this is the another fragment with muscular layer with hyperview of the gland showing. And few of the glands are cystically dilated and few are tortuous, and gland on gland appearance also seen. And epithelium of the glands are columnar with supra and supranuclear and some vacuolations present. So which is similar to the glands seen in the endometrium. So few of the glands usually surrounded by the stroma. The next high overview of the same. And to summarize, this is a 40-year-old female with clinical diagnosis of transition cell carcinoma bladder on histopathological study of transurethral resection of the bladder tumor, which shows bladder mucosa lined by transitional epithelium, and some epithelium shows muscular tissue along with the glands embedded in between them. And these glands are round to oval and tortuous, and few are cystically dilated and are lined by columnar epithelium. And these glands are surrounded by compact perimeter stroma. And impression of bladder endometriosis, the factor favoring the diagnosis of glands in muscularis layer, and architecture of the glands is round oval, tortuous, or cystically dilated, and lining epithelium of the gland, which is similar to the endometrial lining of the secretory phase. And these glands are surrounded by stroma similar to the endometrial tissue. And our final diagnosis is bladder endometriosis. Thank you.
Thank you, Dr. Amrita. Now, Dr. Kushbu will come up to present the case in detail.
Thank you, sir. Now, the history provided was 41-year-old female with a suspicion of BCC urinary bladder and curvature present to us for examination. This patient presented with a history of burning sensation while fasting urine for 2 years and pain lower abdomen, so there was no history of fever or hematuria. On routine investigation, the routine blood and urine emission was very normal image and urine culture was also sterile. Fishy abdomen showed non-full avascular lesion measuring to by 1 centimeter in the right lateral wall of the bladder. On cystoscopy, this growth measures around 2 centimeters and was seen in the right lateral wall near the vesico-urinary junction. However, the vesico-urinary junction was not involved. This is the low power representative microphotograph. Here you can see few of the fragments are lined by the urocerium and underlying in that congested fat vessel. Few other fragments, here you can see the detrital muscle, and here you can see the clusters of the glands intersecting this layer. On higher magnification, to highlight this gland architecture, here you can see these are the glands as brightly pointed out by Dr. Amrita. These are surrounded by the cellular stroma. These glands further, we can see the stroma better in this view, and these glands are tall, columnar, protein are showing secretory activity. On higher magnification, to better highlight the psychomorphology of these glands are lined by the bland-looking cells. Here, the detailed morphology appears bland, no concerning or malignant-looking features is seen. In other areas, there were sheets of this hemosiderin-laden macrophages. On performing IST, the glands as well as the stroma, it showed nuclear positivity for ER and PR. So summarizing the finding, based on this finding, there are this presence of bland-looking glands infiltrating the muscle layer, which on performing IST were found to be positive for ER and PR, both the gland cell as well as the endometrial. So the final diagnosis of urinary bladder endometriosis was made. So coming to the theory part, urinary bladder endometriosis, which is a very rare entity, constituting only about 1% of the total endometriosis cases. Within the urinary system, the most common site to be involved is the urinary bladder, and second most common site being the ureter. Commonly, women in their 30s and the 40s are present with this disease, and usually they have the history of prior pelvic surgery. The most commonly indicated, there are various pathogenesis have been suggested, but the most widely accepted theory suggests that it is because of the transplantation of the ectopic endometrium into the bladder peritoneum, followed by infiltration into the bladder muscularis. These patients usually present with a history of suprapubic back pain and the irritative voiding symptoms, which has a cyclical basis and get exaggerated during menstruation. Less than 20% of the patients may present with cyclical menstrual hematuria, but this is considered to be pathognomic for bladder endometriosis. On investigation, various radiological investigation has been localizing the reason, but the diagnosis is confirmed only by performing the biopsy. Though this patient can be given or can be offered hormonal treatment as well, but it has been found to have limited role. They are found to be helpful if provided as adjuvant therapy to surgery or as a preventive therapy or relapse is after surgery. Surgical treatment is considered to be the treatment of choice. Either local excision or partial cystectomy can be performed depending upon the extent of the disease. So differential diagnosis here, we come across cases of endosalpingiosis or endocervicosis, cystitis glandularis, and bladder adenocarcinoma. So now, how do we differentiate endometriosis from the cystitis glandularis? Endometriosis occurs in females in their 30s and 40s, while cystitis glandularis, it occurs over the wide age range extending from children to adults. Endometriosis is believed to occur as a result of displaced and implanted endometrial cells, while cystitis glandularis occur because of the chronic irritation of the bladder, either as a result of calculi, indwelling catheter, or neurogenic bladder. Now, coming to histology, we have already seen the histology of endometriosis. In cystitis glandularis, it lacks the cellular curve of the stroma seen in the endometriosis, and it doesn't have the stromal hemorrhage and hemocytic deposition. In addition, glands in case of cystitis glandularis, they are lined by the cuboidal to columnar cells showing cytoplasmic nucleus. And if it is an intestinal type of cystitis glandularis, we can find corporate cells as well. In addition, they can be pools of extracellular nuclei. And cystitis glandularis often receives cystitis cystica and von Brunnes also in addition to features. This is how we can help, it will help to differentiate from the cystitis cystica. The second differentiation is the endosalpingiosis. In endosalpingiosis, the glands are lined by the tall columnar ciliated epithelium, and in endocervicosis, the glands are lined by the columnar cells showing cytoplasmic nuclei. In both of these cases, it will lack the cellular stroma seen in case of the endometriosis, and also it lacks the typical stromal hemorrhage and hemocytic deposition seen in endometriosis. The third differential is the bladder adenocarcinoma. Bladder adenocarcinoma is seen in both male and female and typically is present in elderly above 50 years of age. This patient usually present first with a history of hematuria. And the etiology is believed to arise from either as a result of intestinal metaplasia or from the urachal remnant. Now, coming to histology, bladder adenocarcinoma, it can show various types of pattern which are seen in the intestinal adenocarcinoma, like it can show the presence of signature cells, choroid carcinoma, or it can show the non-mucinous type of carcinoma morphology. And in addition, it has the glands in case of bladder adenocarcinoma which exhibit high grade of nuclear morphology. So it will be like definitely malignant looking. In addition, there will be pools of extracellular mucin with often floating malignant cells in there. And stroma shows dysplastic reaction, and it lacks the stromal hemorrhage and hemocytic deposition and the cellular endometrial stroma. Occasionally, we can find the in situ adenocarcinoma, carcinoma in villus adenoma, or papillary urinary carcinoma overlying the epithelium in case of the bladder adenocarcinoma. Other thing we can help to differentiate is the help of biopsy. Endometriosis, the glands are positive for PAX8 ER/CR and the stroma in addition is positive for PIK10 as well. But bladder adenocarcinoma, all these markers will be negative. And endometriosis, it is a benign condition, while bladder adenocarcinoma is a malignant with a 5-year survival rate of 80 to 45%. Thank you.
Any questions? If not, we'll move to the last case. Case number 10 will be presented by Dr. Faiza from Ambedkar Medical College.
Good evening everybody, I'm Dr. Faiza from Ambedkar Medical College. The slide 10 was given to us with a history of 5 years male with the same lesion in the left axilla since 6 months. The image had 4 sections. On a low power, we could see that there was a structure of the skin with epidermis and dermis. The epidermis was thinned down with the less prominence of brittle edges, and the lesion was occupying the whole of the dermis. Then we see that the lesion was separated from the dermal epidermal junction by presence of red zone. And then on the same magnification, we are seeing that there's a nodular lesion which is separated from a thin fibrovascular septa. And there was preservation of these adnexal structures. Here also we see the red particle with preserved adnexal structure. And then we see one of the sections has shown the fibrovascular septa has a cushion border indicating an inflammatory type of lesion. This lesion was composed of giant cells with lymphohistiocytic type of proliferation. The histiocytes are the protein histiocytes, and these giant cells are the Teuton type of giant cells with centrally placed ring nucleus surrounded by the cytoplasm, which was seen on highlight magnification. Apart from that, in a higher magnification, the 48, we have seen that they are also present on other multinucleated giant cells. So, predominance of the histiocytic type of cells. So, we classify the histiocytic disorders into two types. First being the Langhans cell histiocytosis and the non-Langhans histiocytosis. In Langhans cell histiocytosis, we have the morphology where they have a reniform nucleus with a central lumen and there is a presence of eosinophils. In the in the non-Langerhans cell histiocytosis, the examples are the Joanna and Xanthogranuloma, where we see there is presence of lymphohistiocytic proliferation and Teuton type of giant cell, and Xanthoma disseminatum, where there is a occurrence in the all age group with predominance in the elderly age group, and there is a presence of the lymphohistiocytic proliferation and Teuton giant cells. In acute ulcerative disease, we see that there is the involvement of the bones, which is seen in Rosite outfit. The most characteristic microscopic feature we see is that emperipolysis. And atypical fibroxanthoma, where we see there is a presence of atypical mitotic figures. In reticulum histiocytosis, we see then other type of vision, and there we see the presence of ground glass appearance of the histiocytes. So coming with the differential diagnosis, based on the slide and the history we have received. The first one being the Joanna xanthogranuloma, then Langhans cell histiocytosis, xanthoma disseminatum, and dermatofibroma with hybridized component. Here we see there is a spindle cells will be arranged in a story-form pattern. So we finally conclude that with a history of 5 years and microscopy showing lymphohistiocytic proliferation with the phony histiocytes with Teuton type of giant cells which we see, we will come to a conclusion that it was a Joanna xanthogranuloma, also called as nevoxanthoendothelioma. To just highlight on the microscopy, we have markers, that is the Langhans cell disease was are positive for S100 and CD1A, whereas Joanna xanthogranuloma is positive for CD68, and Rosai-Dorfman's disease, which is positive for S100 and CD68. Thank you.
Very nice presentation, Dr. Faiza. Now I invite Dr. Ranjana to discuss the last case.
So this was a 5-year-old pale boy who presented with skin lesion in the left axilla, which was present since 6 months. So grossly, we received a single skin covered tissue with solid gray white homogeneous lesion measuring 0.7 to 0.5 centimeters, and it was reaching almost up to the base. The scanner view, wherein we can see the epidermis and the underlying dermis showing multi-nodular lesion. The epidermis appears very unremarkable, and separated by particles of spindle cells. And we can also see few multinucleated giant cells. The high class view, where we can see the histiocytes separated by particles of spindle cells and few lymphocytes. And also we can see inflammatory cells. These are mostly multinucleated giant cells. These are the Teuton type giant cells, and here we can see Langhans type giant cells. And this was reaching up to the root base. So our diagnosis was juvenile xanthogranuloma. Juvenile xanthogranuloma is also called as nevoxanthoendothelioma. It's a normal epidemic histiocytosis composed of cells originally thought to be derived from dermal dendrocytes. However, subsequent studies have suggested that plasmacytoid oocyte to be a more likely precursor. And they usually present a solitary or multiple red-brown macromolecules around 1 to 10 mm diameter. Commonest types being headed leg, upper part of the trunk, and proximal part of the limb. Onset is within the first 6 to 9 months of life, and 5 to 10% present at birth. We report rest, and they undergo continuous evolution within months to years. And similar condition of systemic tuberous granuloma has been reported in monozygotic twins. And this has been reported to be associated with neurofibromatosis, neoplastic disease, contralateral lymphadenopathy, arterial leukemia, lymphoma, and arterial amyloidosis. Microscopically, lipidologist shows involvement in lesions, distribution of pregnancy, dense leukocytic proliferation in dermis, short vesicles of microdystrophic cells and spindle cells, two-tone type child cells and other types of child cells, leukocytes and eosinophils, and no microcytes. And these two cells are usually positive for CD16, cathepsin B, negative, factor 13A, and passive. And staining is usually intense at the periphery of the lesion. Treatment includes simple tumor excision, except in the rare systemic forms wherein multimodal chemotherapy is indicated. Differential diagnoses include dermatofibroma, where we can see there is a cholangiostroma with storage of growth factor, and clavicular and histiocytosis, which will usually show nuclear growth and will be laminate positive, and here will show with granules. Reticular histiocytoma will show prominent ovocytic histiocytes with eosinophilic and ground glass appearance. Any questions?
Thank you, Dr. Rajna. So now we're done with all the main cases, and let's get back to our interesting part of spotters again. Yeah.
Moving on to spotter number 6, the history is 25-year male who presents with a history of nasal obstruction on and off past 6 months. And examination is probably like polypoidal mass was seen of filling the nasal cavity. No chocolate. So this is the story. So now moving on to case number 7. TEL male presented with nodular lesion measuring 2 by 1.5 centimeter in the subcutaneous plane of the upper arm and exceeded was touch. This is the representative. Yes. Moving on to case number 8, 5-year male child presented with multiple light lesions of the skull. This is the representative photo. Higher magnification. Can you give a higher magnification? Should I point out? No. They are the eosinophilic site of the inflammatory cells. Yeah. So these cells are positive for PD1A and action, right? This is the case of our sketch. Case number 9. 45-year female presented with dull egg upper abdomen. The entity scans through the hypervascular mass in the right lobe of the liver. This is the representative broad photograph showing central stimulated cast, microscopy, iron magnification. This is another photograph showing nodules. There are these heptags showing regenerative modules. This is the central steelage car, which is emanating and encapsulating these regenerative nodules of hepatocytes. Here at the periphery. Yes, that's the correct. So now moving on to the last quarter, 65-year female presented with inverted nipple and scaling and crusting of nipples. This is the low forward message. Please raise your hand. Okay. So this pellet cells were positive for CK7 and HER2. And in addition to that, the other underlying well shows the focus of TCIS and the cancerization of nodules also. So the diagnosis of pellet cells of people with underlying TCIS and cancerization of nodules.
Thank you, Dr. Krishnu. A quick word of thanks. I would like to begin with a big thanks to KCIAPM for letting us organize the sixth slide seminar. This was the first time we hosted it in Manipal Hospital, Bangalore. And we thank all of you. Please wait for the certificate. So we thank all PGs, both who presented and those who have participated here, and all other pathologists who are listening to us here as well as on the online forum. Hope this event was useful to all participants. A sincere thanks to the entire team of Manipal Hospital Administration, lab team, IT team, and the supporting staff who helped us manage the event really well. A big thanks to Dr. Aditya at SDNC Dharwad and the social team under the KCIAPM for patiently guiding us throughout the online broadcasting process. It was a little tedious in the beginning to understand, but hope it has been successfully aired. So thanks again and good luck to all the students in the future. And have a great evening. We break for tea and snacks now. Thank you. Thank you. A quick announcement, the certificates are kept on the table outside. You could pick them up on the way back. Right. Students, can we have your attention again? We have another announcement to make. There is a special prize for two best presenters here. So we'll just call out the names. You could just come ahead near the stage to collect the prize. So sorry for the inconvenience. Just a moment.
It's a request from Dr. Mahesh. He is our lab director, and I think all of you must be knowing him. He is a nephropathologist and very well known to the whole of Karnataka, and now I think even all of India. And so we're just calling him after the stage. He will be handing over the certificate and the gift to the best presenters. Please come, Dr. Mahesh.
A little more suspense. So the two top presentations that we have selected here will invite Dr. Mahesh to come to the stage to issue the award. The first Best Presenter Award goes to Dr. Ashwati Pradeep. Dr. Ashwati is from KCIAPM Medical College and she presented case number 7. Congratulations, Doctor. Second award goes to Dr. Faiza from Ambedkar Medical College, which will be presented by Dr. Sushmita. Congratulations. Very well presented. Thank you. And now you can snack on the tea and